Hi everyone, thank you for joining us again for another episode of BAEP Talks with, where we speak to a person of interest who has experience living with, managing, treating, or supporting persons with a chronic menstrual health disorder. My name is Julia Mandeville, I am your host, and today I'm very happy because we are joined by our own President, Jasmine Evelyn. Welcome, Jasmine. Thank you. It's great. Thank you. So a little about Jasmine. Jasmine is, along with being our president, she is the founder of Mindful Movement, which is a yoga and physiotherapy practice. She obtained her degree in physiotherapy in 2013 from the University of Brighton in the UK, and then she also got subsequent postgraduate training in pelvic health. She also did 200-hour yoga training and is a registered yoga teacher. So thank you again for joining us, and we're hoping to have a really enlightening discussion about pelvic health and pelvic health physiotherapy. So I'm going to just, jump right in. What is physiotherapy?
So physiotherapy, when most people hear it, they think sports injuries, you always see a physio running onto the football field, they think about that, but really and truly, that is one aspect of it. But physiotherapist is a person who uses different modalities and first and foremost, the exercise as a way to help you reach your goals. Okay. If you have like pain or if you have loss of function, so sometimes you have patients come in, they're not even in pain, but they can't do something that they used to be able to do. So any pain, loss of function, if you're not moving the way you want, your physio is a person who's going to help you, and they're going to do an assessment, and then based on how you present based on your goals. So the thing about physiotherapy is it's not cookie cutter. Just because you have knee pain and your friend has knee pain doesn't mean that you're going to have the same treatment. Right. What you want to do with your knee is not what your friend wants to do with their knee. So it's very customized based on your goals and what you want and on your lifestyle, right? So physiotherapy, there are many different types of physios. There are physios who specialize in areas of mental health. There's some who specialize in areas of, most of us know, sports, orthopedics, neurology, pelvic health, many other areas, amputees, aqua or hydrotherapy, cardio, pulmonary physiotherapy. A lot of them are working right now with the patients who have COVID, right. And really physios are helping so much because here you have people who have not been moving for a long time. They've been on ventilators, so they're going to help them to breathe properly. They're going to help them to get up and moving. They're going to help them to be able to get back to what they used to do faster. So that is really what we do.
I have an even greater appreciation for the field. So what is the difference between physiotherapy and physical therapy, if there is a difference?
There's no difference. So most likely a physical therapist has graduated in Jamaica or in the US. Okay. Or I'm not sure what they're called in other, like Australia or New Zealand, but I know for sure in the UK, when you graduate, you're a physiotherapist. It's the same thing, but just a different term. There are differences in terms of, for example, in Jamaica and in the UK, the program is a 3-year undergrad. But then in the US, I think they do some undergrad training, and then the physio program is a postgrad. So then they are DPT, doctors of physio, after they graduate.
So, okay. Are you then specifically a pelvic health physiotherapist, or do you deal with the whole gamut with the exclusion, I guess, of like developmental physiology, physiotherapy, that you mentioned earlier?
Right. So when I graduated from physio school, you have to do your rotations, your cardio rotations, your neuro rotations, etc. But I kind of got into outpatient physio, which is like neuromusculoskeletal, so dealing with your knees, your backs, neck pain, shoulders, etc. you will see a sports injury from time to time, but what I say I'm a sports physio, if I had like a really elite athlete, first of all, I probably wouldn't get them referred to me in the first place. And if I did, I would be like, well, you need to go and see a sports physio, right? But I would say I'm a outpatient MSK physio, but then part of being a pelvic health physio, so a really good pelvic health physio is usually a MSK physio to my mind. Right. Because the thing is, we still have to, when you come with your pelvic health condition, we still have to assess and rule out other things, like your back, your hip, other things, right? So it's not just your pelvis or your pelvic floor in isolation. It is, we look at the whole body and we assess you that way. Sometimes we can't do all of it at the first assessment, but we will try and then we will leave some for the next visit. But I still treat, and I work in a medical clinic, so I will get there, I would get the one-off cardio patient, which I enjoy, but it's not, I wouldn't say I'm a cardio physio, I can do it, but I'm not one of the hardcore cardio physios in the hospital who are, suctioning patients and putting tubes down people's noses. If I had to do that, I would need a refresher.
Oh, okay.
I'm a MSK patient, I'm pelvic health physio.
Okay, so then I'm going to ask my questions a bit out of order then. What drew you to the focus on, I guess, the pelvis and the pelvic floor and everything related to that, as opposed to any of the other avenues you could have taken? Yeah, so at physio school, I thought it was going to be, well, when I went into physiotherapy, I thought I was going to be a physio. I was going to come back home and focus on dancers because I love dance. Right. And I figured wherever I go, I will be a physio who focuses on that. So then when I got to physio school, I also like the neuro physio, dealing with strokes and different things like that. But then we had options when it came to choosing your elective. So you have to do certain rotations for your clinical, but you can choose one kind of novelty. So then you could choose like peds, or you could choose amputees, mental health. I decided to choose pelvic health. Well, at that time it wasn't pelvic health, it was women's health. Right. And I thought I was always into, I always said that if I was a doctor, I'd probably do obstetrics and gynecology. Okay. So I was like, oh, women's health, this should be interesting. It would be fun to, work with pregnant women all day. That's what I thought it was. That's honestly what I thought it was. Right. And then I was like, I remember going home and telling my roommate, I hope I get this placement. And then, because I thought it was so interesting, but then when it came around to the day when you found out what you got, I was the only person who signed up for it. Oh. Everybody else was like, nope, they don't want to deal with looking up people's, needs. But for me, I was like, even if I do have to do that, I don't think it's a big deal. Right. I went to the placement, and it was not what I expected. As I said, I was expecting to be teaching, pregnant women how to exercise, that we were going to be, rolling around balls all day, doing the mass classes, but it wasn't that. That's when I started to learn about pelvic organ prolapse, which I guess we'll talk about, and all these things that for me at the time, honestly, Julia, it was scary because I always say when people ask me at physio school, you don't learn about the pelvic floor. So this was the first time she had to explain to me, my educator, what it was. And I remember looking at diagrams and thinking they were so confusing. And so I know what it's like being a patient and learn about your body and learn about the pelvic floor and prolapse and all these things for the first time, because I know what it was like being completely mind blown when she explained to me what was happening. And I thought, I don't know if there's anybody else at home doing this. I've never heard about this. And it can't be just people in England who are suffering from this. I mean, women at home have to be struggling. And so that's when I say, you know what, this is what I'm going to do. And that's why I got into it, basically. So we're talking so much about it, but what's the pelvis? So the pelvis is, if you are sitting right now, you're basically sitting on your pelvis. So your pelvis is basically, it has many functions. One of it supports your pelvic organs. It protects them, right? Right. And can we list the pelvic organs for everyone? Pardon? Can we list the general pelvic organs that are found within the pelvis? So for women, your uterus, bladder, and rectum, and in men, prostate, bladder, etc. I'm sure I'm leaving out some, but yeah, those are the basic ones. Right. And
That's a good segue actually. So whenever I try to explain the pelvic floor to patients, I say, well, you have your pelvis, it's a bony structure. And if anybody has heard me talking before, they know I always say the pelvis is a bucket without a bottom. It's supposed to hold things, but the bony pelvis doesn't have a bottom on it. But it does in that it has the muscles, right? So if you just look at the bony pelvis, you can see right through. So there has to be something at the bottom that's keeping everything up and supporting everything, it goes all the way up to your abdomen, right? Your pelvic floor muscles are at the bottom of those, and they have to take the weight of everything in your abdomen right down. So that is basically the pelvis and the pelvic floor muscles. They attach front to back, side to side, and they wrap around the anus, which is where we stool from. I explain this to patients all the time, the vagina. And then in men and women, the urethra, which is where we wee from. Right? So that is at the base of your pelvis. So if I always tell patients, Google the pelvis, Google the pelvic floor, and you will, get an idea of what it looks like. Okay, so everyone, please, after this, Google what the pelvic floor. And remember, I feel like I should have my stuff, but remember that men and women have pelvic floors. It's just when people think pelvic floor, they think women. Women specifically, yeah. But it's because women have a lot of life events that happen around the pelvis, right? There's their menstruation, there's childbirth, maybe pregnancy, and menopause and all that. So there's a lot happening down there, and that's why people will think more women, but men and women have pelvic floors and can have pelvic floor dysfunction. Also important to note that your pelvic floor muscles are just like the muscles in your arm, like your biceps, muscles that you can control, right? They're muscles that you can relax and contract voluntarily. But they also work for us without us knowing. So when you sneeze, cough, etc., they will do their job. Right. Yeah, they will give a little squeeze so that you don't leak anything. So they work for us and we don't know it, but we can actually squeeze them and relax them ourselves. So is that what a Kegel is? Okay. Right, that's what a Kegel would be. So what are some of the common, conditions, ailments, disorders that you see in your practice when patients are coming to address something with their pelvic health, both male and female? Yeah. So let's just go with male first, just to hit home the fact that men can have. Usually I will see men who have had prostate surgery and who have some kind of incontinence or bladder issues afterwards, or erectile dysfunction, right? And so pelvic floor works to keep you continent, which means it stops you from leaking urine. So it will give a little squeeze to close your urethra, which is where the tube that comes out. And it also has an intimate relationship with your bladder. So when your pelvic floor muscles, let's say I'm talking to you and I need to go to the bathroom, they will contract and tell my bladder to relax. So I don't have the urge anymore. Right. Then when we get to the bathroom and I sit down, they will relax, and then my bladder can contract and let the urine come out. So incontinence in men, as I said, erectile dysfunction. So erections come because, yes, blood fills the penile tissue, but also the pelvic floor muscles will give it a lift. Okay. So if you get a man to do a Kegel, you will see his penis move up. Okay. So the important for that reason in men. Now, in terms of women, a lot of times I will see, let's say, pelvic organ prolapse, which is a common one I see often, which is when the organs in the pelvic area, so it could be your bladder, it could be your uterus, or it could be your rectum, they come into the vaginal space, right? They're not supposed to do that. Right, they're not supposed to do that, right? And that can be, it sounds scary, but it's not really. You always tell patients it's not life-threatening. You don't have to feel that something is going to happen. So I give a lot of reassurance when it comes to that. Also, incontinence, there are different types of incontinence. So you got stress incontinence, where you sneeze, a cough, laugh, jump, and urine comes out. There's urge incontinence, where you always have this urgency, this frequency to go to the bathroom, and they can be mixed incontinence. We have a bit of both. Also, I see a lot of, and I don't want to use big words, so I just go with pain with sex. So women who are having painful penetrative sex, or women whose pelvic floors cannot relax enough for them to be able to have penetrative sex. And that can be very distressing in a relationship. And so I help them with that, help them to relax their pelvic floors. What else do we see? We'll see patients who have endo, and other symptoms are coming from the fact that, and this is, I don't want to get too, complex, but let's say you have endometriosis, you're having pain during your period, before your period, after your period. You know how it goes, Julia.
I know how it goes.
Yeah. And so the natural response is for your pelvic floor muscles to contract, right? To tighten. And that can then lead to pelvic floor. That is a dysfunction in itself, and it can lead to other things, right? And so I always say the pain of endometriosis causes other symptoms. Pain is a symptom, but it causes other things, other dysfunctions. So if you think about the fact that you're having pain, the pelvic floor muscles are going to be contracted. And what happens is that they learn that pattern of contraction, right? They kind of almost forget how to relax. And if muscles are contracted all the time, they're going to get tired. They're not going to be able to do their job. So just because, these pelvic floor muscles are tight, they're still going to lead to things like incontinence. You might find that a person who has endometriosis is always constipated. So they might be straining a lot on the toilet, which then means that they're pushing on their pelvic floor muscles, pushing on their pelvic organs, which can cause a prolapse. So people think, how can you have a prolapse with muscles that are tight? That is how, because they're putting a lot of downward pressure on those muscles. Again, the muscles aren't relaxing, so they may have pain with sex. And a lot of the other things, interstitial cystitis, which I always hear along with endo. And a lot of times it's those tight pelvic floor muscles that give you that feeling of burning, wanting to go to the bathroom frequently, kind of almost an irritable bladder. So, and those patients are always the very interesting patients to treat because there are usually a lot of different things going on. I always say I remember when I first started doing my pelvic health, I had a patient who had just had a baby and she was having incontinence, and I thought, oh yeah, that's easy. You just need to strengthen. And then when I did the assessment, actually she was having, the pelvic floor muscles were tight. It was sore in there. And so I had to teach her to relax first because her pelvic floor muscles had just overstretched, pushing the baby out. And now they were kind of guarding and healing in a contracted state. So sometimes it sounds, you may think a person with endometriosis has to lengthen their pelvic floor and relax, but really and truly you may assess that person as a whole different story. So it really depends on the person. That's why I never will tell a person that you need to do Kegels or you need to lengthen. I always say I have to assess you first because I don't know how what you have is impacting your lifestyle and how that lifestyle is impacting your pelvic floor. So it's very, very specific.
So it will never be cookie cutter. It'll always be a case-by-case situation.
Yeah.
I think that's comforting to know that you take the time out to do that assessment with every single one of your patients.
You have to, because everybody, and I have to make sure what my goals are. I remember I had a patient who she couldn't have, I think she had a traumatic experience with a pelvic exam. And I thought, okay, well, you have a boyfriend. Your goal should be to be able to have penetrative sex. That was not her goal. Her goal was to be able to have a pelvic exam. And I had to respect that and not let my goals
infringe on.
Yeah, I have to go based on what they want. And as much as she did want, yes, that it was not her main goal. So you have to work on each person's goal and with each person.
It just kind of reiterates what we as BAEP want. We want that patient practitioner relationship and communication, bidirectional, communication. Exactly. Okay. Are there practices that we as human beings just generally do that are typically damaging to our pelvic floor and its muscles that we should really try to avoid doing?
Yeah. Okay. So as you said that, a list came into my head, but my head. So let's see if I can remember all that flew in. So the first thing I would say is we rush toileting, right? So I always tell some patients, and this goes for anybody, toileting And I heard a quote saying it's called a restroom for a reason. Go in there, sit down.
Sit down.
And the way I emphasize sit down is because sometimes when we squat, our pelvic floor muscles and our hip muscles and everything are still working. So which is important for a person who has difficulty weeing. So sometimes your pelvic floor muscles are really tight, they don't relax when you go to wee. So you will be there and nothing is happening, right?
Like what if you go to a public bathroom? That's
exactly. And I wrote an article in Better Health. I remember saying, I know I do it. I also squat, but you know, especially if you can lay in the toilet, especially if you're a person with a dysfunction. You know, the average person, okay, squat is okay, but squatting can, as I said, still have the muscles working, and so you don't get as efficient, we will call it voiding, weeing as possible. So sitting on the toilet and relaxing. People get on the toilet and they're like, okay, I have to get ready for work, and they push, right? That pushing and that constant straining, extra, as I said before, pressure on your pelvic floor, pressure on your pelvic organs. Think of it as you're pushing them out, you know? I want it to be scary because I want people not to strain. I tell my patients, nobody should be straining. So drink your water, eat your veggies, exercise as best you can, move, because that will help the motility of your bowel. Right? Usually when people are become bedridden, they get constipated, or if they're like wheelchair bound, a lot of times the movement of their bowel, movement helps your bowel to move. So try to move, fruits, veggies, water, right? Take your time when you go to the toilet. The second one I would say would be breathing. So our diaphragm, breathing and posture. Our diaphragm and our pelvic floor have an intimate relationship. So most of the times when you look at your pelvic floor in diagrams, it will be like this, like a hammock. But actually it's shaped like that. Like that. So in the diagrams, it will look like this.
Right.
It's like a little diaphragm.
Okay.
So you have this diaphragm in your pelvis and this one in your chest under your ribs. Right? Okay. So when you take a big breath in, this will press down. It will create pressure between the two, and this will press down. Yeah? So you can imagine that if you have a tight pelvic floor, taking a big breath in will lengthen it and stretch it. As you exhale, they will do that. So all during the day, you have this relaxing and contracting of your pelvic floor muscles, and that helps to keep it healthy. Now, if you are a person who's slumped or you have this posture where you can't take those big breaths, you'll find that your pelvic floor muscles are not getting that relaxing and contracting, that gentle movement during the day. And oftentimes that can result in a pelvic floor is kind of stuck in one position, right? It's kind of a more overactive pelvic floor, if you will. So being mindful of your posture, and really when you know, people don't think about breathing, but really taking good big breaths, and a good way to help with that is to have a great posture so your body has room to breathe. Right. The other one I would say is people who like to hold their urine. So for example, you don't like the bathroom at work, and so you wee before you leave home, and then you try to go through the whole day. You don't drink any water because you don't want to go to the bathroom, and you hold it in. So two things are happening there. You're dehydrated, which is not good for anything, and your urine is becoming concentrated, which is more likely to irritate your bladder, right? But we're not going to go down that road. The pelvic floor muscles are working hard all day long,
trying to keep that.
Right. And then when you go home on the evening, then you finally wee. And then what happens when you do this for years? I know people who do this for years, and then I'm trying to figure out what happened. What happened at your pelvic floor so tight? Did you have surgery? Did this? I'm asking. And then when I ask them to fill out a bladder diary, I see that they go to the bathroom at 7:30, and they're drinking tea, a little bit of tea, a little bit of coffee, 2 drops of water, and then they go to the bathroom in the evening. And I'm like, what is going on? So that can be a reason, not go to the bathroom when your bladder tells you to go, try to go, I mean, you can hold it for the first urge, but try to go shortly thereafter. And then on the opposite end now, and there are other things, but just to keep it, you know, on the opposite end, going to the bathroom just in case. Now, there's some people, some people will, especially you find somebody had an accident once, or if you find that especially you will find for children who were taught, go to the bathroom now before you leave.
Right.
That way, I know as parents, it is tempting because you don't have to stop while you're on the road, or you don't want to, you know, you don't want to use a public bathroom because children touch everything. But sometimes that is a really bad habit to start in young children, because it can carry on and it can also have its own implications while they're young, right? The reason why you shouldn't be doing it is because your bladder never gets a chance to fill up. So your bladder is kind of, it is a sensory organ. So as it fills up, as it gets, those stretch receptors will say, okay, time to go to the bathroom. But sometimes what happens is that because you're going so frequently, it never gets a chance to fill up. And if you don't use it, you lose it. So it starts to just say, well, I never get that big, so I could just stay this size, or it will shrink. And then you'll see patients there who have this like urgency and frequency. They have to go to the bathroom all the time because they don't actually have the capacity. And then sometimes you have to then do bladder training where you will say, well, when you get the first urge, you know, try to hold, or you would tell them certain days to drink extra water. So you're actually trying to retrain their bladder literally, and it can be quite a complex.
Right, because it's also a mental thing as well.
It is, and you'll find those persons will hear a stream of urine and feel, not urine, hear a stream of water and feel they need to go to the bathroom. You'll find those persons will get home, and as soon as they get home, like they'll be fine driving home. And then as soon as they turn into their driveway, they put the key into the door, they have to run, or something to even leak on the outside. So it's important to go when you need to go, but not go just in case.
As I was researching for this session, I came across this concept of biofeedback. Is that something that you had to study, and then are there tools and techniques that you use with this particular concept?
Right, so there are two types of biofeedback. So there's the like almost using equipment, we use electrical biofeedback. So I don't use that. I would use more manual biofeedback. But when it comes to electrical, like where you're using an actual machine, it can be quite effective, especially for patients who have no idea. I guess it would make my life easier in some aspects, because there's some patients who have no clue what to do, right? In terms of contracting or relaxing their pelvic floor. And so with these devices, usually you can insert a probe into the vagina or the rectum, and they will see on a monitor. So for example, as they squeeze, they will see that they're going up a hill, and as they relax, they're going down a hill. So it will give them biofeedback as to what they're doing. Yeah. But in terms of me, I would use manual biofeedback. So a lot of times I will tell some patients, you know, sometimes every time you come to physio, especially in the beginning, I might have to do an internal, have to palpate internally. This is to give you feedback. There's some patients who I just need to do it once and they know, okay, those are the muscles. Because the thing is, with the pelvic floor, you can't see it. You can't see them contracting, right? And a lot of times, the fact that people can't see it contracting, they contract the wrong muscles, and they will squeeze their legs together, or they will squeeze their glutes. And when you are doing a pelvic floor contraction, nobody should be able to see. Nobody should be able to tell. So sometimes when I insert my fingers, I can, first of all, tell, because we're talking about biofeedback, let me just stick to that. So I will insert my fingers, and I can say, okay, give me a contraction, give me a squeeze. And I often use the analogy, imagine that you had a little marble just by your anus, and you want to pick it up and pull it inside. And I will see what they do. Sometimes I will see that they're squeezing their left side more than their right. And I can give biofeedback then and say, okay, you a really good squeeze on one side, but this side tap. Can you feel me tapping there? Squeeze a little bit more there.
My next question, you mentioned that you see pregnant patients. So with that, do you specifically see them like at what stage do you see them along their pregnancy? Do you see them all throughout? Do you see them towards the end?
It all depends. So usually when I see pregnant patients, it depends. So some people will know of me and have heard of me, and they will decide that they want to come early in their pregnancy because they want to learn how to do their pelvic floor contractions in the early. They want to learn what exercises they should do in the early. Not only pelvic floor, but just to keep their body going throughout, right? Remember, your physio is not just a person that you have to see when you have dysfunction, but you can see them because you want to reach a particular goal. And for them, this goal will be, I want to keep moving during my pregnancy. I want to do this safely. Let me find out from my physio what are the best exercises for me to do. And you can give them a little program and they can run off of that. Sometimes though, I do see pregnant women who are having pelvic pain or back pain. So sometimes the joint at the front of the pelvis, the pubis, can be very sore. And even the SI joints at the back, the big joints at the back, can be very sore. And so I am doing gentle manual therapy, whether it is gentle massage or actually giving them gentle mobilizations. And a lot of times it's education. So a lot of times when I'm giving them advice, they're like, oh, right, I didn't think of that because it sounds ridiculous. But they, it's my job to think of these ridiculous things. Like, do not lift a heavy bag of dog food every day. Maybe only lift it once a week. So put it in a smaller container. And then you can, I teach them how to get in and out of a car so that they don't have to open their legs wide, and you teach them how to get in and out of bed. So simple things like that. And usually when I have pregnant patients, they're not really patients that I'm seeing every week, twice a week for a long time. Because I find a lot of times I would give them advice and I would give them tools to use at home. And then if they need to see me again, they will come back. If persons are incontinent or having any kind of incontinence during pregnancy, I will assess, maybe teach them the pelvic floor exercises, and then they can run with that. If they need extra help, I can help them with that. And then they will probably come again after they have delivered.
Right.
Yeah. And then I will obviously see them after, depending again, if they want to, if they feel that, I need some extra help. But especially if they're having persistent pain around their scars, so like their C-section scars, if they have an episiotomy, there's a little snip in the perineum, like in the vaginal area, or if they had a tear when they were giving birth. Also, if they need core retraining, because sometimes the core muscles don't really work efficiently afterwards, or there's still a space, we call it diastasis recti, and so it will help them to kind of gain their core strength, because core and pelvic floor work together. Your pelvic floor is really part of your core, so helping them to strengthen that up.
Does an individual need to get a referral in order to see?
You can call and come straight, but what I always tell patients, feel free to come in, but if you do want to claim on insurance for your physio assessments or treatments, it always is better to get a referral from your doctor, because then the insurance will require that, right? So they can come straight in. I mean, in Barbados, I think in some countries, physiotherapy are first access points, because they realize that can relieve some of the congestion at the GP. And a lot of times, person will say, I don't really want to go to the doctor, and then they prolong that visit, which prolongs their referral to physio. So they find that like nipping things in the butt, like back pain, etc., is better if physios are first access points, so they will go straight to the physio. But I don't think that is the case in Barbados. So for example, that's why you would need a referral if you want to claim on your SAGIC or ICBL, etc.
Insurance. Okay. And then for women who are not pregnant, but they still want to come to you again, they might have endometriosis or PCOS or uterine fibroids or whatever. Can they come to you at any point during their cycle, or are there suggestions when it comes to that, especially if you might have to do like an internal examination? So
this was something we covered in my training, and you can come to your pelvic health physio at any time, but it's if you are comfortable. I don't care, it doesn't matter. for me. But there's some people who will say I prefer, and they will call me and say, actually, Jasmine, my period came early, and I prefer to, have my appointment next week. That is no problem. It's what you're comfortable with. I've had some patients that are like, look, I need to come is painful. I just want to make sure it's okay with you that I have my period. And I believe that is absolutely fine. So there's no need to not to come. Don't let having your period stop you from going, but don't be uncomfortable and still go, because your pelvis and your pelvic floor are very much connected to how you feel emotionally. So if you come to me, you're coming for overactive pelvic floor, and you think, I don't really want to be here because Jasmine is going to see that I'm bleeding, you're not going to relax. Yeah. And it's totally counterintuitive, so counterproductive. So if you're not comfortable, don't come. I also tell patients when they come to me, I always say, if you don't feel like having a vaginal or a rectal exam today, just say, call and say, like, don't come here and don't have a procedure done that you don't want. So it's important to just go with how you feel and communicate this to your health, to communicate to me or to your healthcare provider.
I wanted to know how comforting that is, like, to hear that the practitioner is willing to work with you and your comfort levels.
Yeah.
I think a lot of persons who might be listening are going to recognize, this is something that should be the norm, where, your practitioner is very cognizant of your discomfort, because, for some people, unfortunately, a lot of the times, like you said, there was your patient who had a traumatic examination early on. I don't know the reason behind that, but the point of the matter is sometimes the patient-practitioner relationship can be a very stressful one, especially if there's not that communication there. So I'm just happy that you model that, basically, that
Yeah, obviously we're not talking about, patient advocacy right now and all that, but as you know, we had our patient advocacy event.
Yes.
And I was said at that event, I always say practitioners need to remember that, especially private practitioners, so any practitioner is the place to, but especially private practitioners need to remember that it is a privilege that these people have chosen to come to you. They are doing us, we have a service that we can offer them, but they're also doing us a favor. They are the people that are paying our bills. They're the people, they are employing us.
Right.
They are in control. It's just like the customer is always right. They are, it's their session that they've paid for. So I always say, if I'm doing the vaginal or whatever, I say, you're in control. If you want me to stop, if you feel uncomfortable, if you feel too much pain, tell me. Yes, obviously it's a relationship where I am the healthcare provider, so but still, it's still a relationship where this person's opinion and how this person feels is the most important thing at the point in time. So I said it at the patient advocacy forum that we had, and I think it's something that more people need to take on board.
Are a registered yoga teacher, so how does that practice influence your profession and vice versa?
Right. Oh man, I could talk about that in a lot of different ways, but I guess, no, obviously all exercise is good. I am a yoga teacher, so obviously I love yoga, and I think that, our Prime Minister, the Honorable David Thompson, that we had at one point, I remember he said he wanted a UE graduate in each house. You remember?
I remember that, and I think it was also Sir Hilary Beckles as well.
Yes, they said they wanted a UE graduate or was it Sir Hilary Beckles? Anyway, somebody said a UE graduate in every household, and I feel like one of the reasons when I remember I discovered yoga for myself, I thought I would love if almost every household in Barbados is somebody who knew about yoga, or at least had an experience with yoga, even if they're not a person who does yoga all the time. At least they've had an experience with yoga and or mindfulness.
Right.
Because I remember I had a patient once, horrible neck pain, and she got better and she came back. And I thought, okay, I have to do something differently. But, you know, it was still like we were doing weights and stuff, and she would always come back and say, you know, I feel okay when I leave here, but then when I go home, I feel really sore. And I thought, okay, I need to do something different. And at that point, I was not a yoga teacher, but I was just practicing. And I decided, you know what, let's try something new. And I took her through some yoga exercises. And remember, she said, you know, afterwards, at the best she had felt, she went home and she didn't feel sore. She felt a lot better. And from then, that's when I decided, you know, especially for people who have ongoing pain, because when you have ongoing pain, it's more than just the physical. Then it's a lot of learned patterns, and it becomes emotional and mental. So I find that yoga is a good tool to help with that. And that's why one of the reasons why I did my training was to help my patients. And so my practice, when you come to my clinic, there's no like treadmill or anything. Is mainly a yoga setup. There's not much stuff on the. I have a lot of floor space, because I want it to be a space for yoga and mat work and movement. Okay, I did yoga training.
Right.
And then I think I did my pelvic training after.
Oh.
Yes, I did yoga training first.
Right. Okay.
When I did pelvic training, I feel like, if not 90% of the exercises recommended were yoga. And then even at the pelvic pain conference that they have every year, there's a yoga session in the morning. So yoga and pelvic pain, pelvic floor rehab are very closely linked. So I remember when I did the courses, then I was like, yes, thank goodness that I did.
You did the yoga.
Because this is perfect. Because I love all of these exercises. I understand and I can see why they help, and I've already been kind of using them already with my patients. So I would say they both influence the other, and they both marry well.
So you've given us a lot of information, a wealth of information, to be fair. Are there any last words or comments that you would have for our audience?
I would say, and I just want to speak specifically to persons with endo, right? I want to speak specifically to persons with endo and persistent pelvic pain. So it could be a person who has PCOS and they have persistent pelvic pain. Remember that you don't have to, yes, you have pain, but you can use pelvic health physiotherapy as a way to help. I will admit to you, I knew that pelvic health physiotherapy was important in the management of patients with persistent pelvic pain and endometriosis. But it's not until I read that book that I realized how much I am not pushing that, and how much I can help people, and pelvic health physiotherapy can help these women. And I think I took that for granted. So I think it's important to realize that your quality of life can be improved. And you don't have to come to the physio all the time, but you can get tools from the physio that can help you. You can learn how to breathe. You can learn how to exercise effectively. You can learn how to do your own manual therapy. You can buy the tools to help you, and your physio will teach you. You can employ, if you have a partner or a family member who's willing to help you. And, you know, there's so many things you can do. Remember that it's not just the endometriosis. The endometriosis is causing pain, but the pain is perpetuating that pain. If you understand?
I completely understand. It's a cycle.
Pain is perpetuating that pain, and the pain is causing causing this pelvic floor dysfunction, which is causing you more pain, which is causing you other symptoms and other dysfunction.
And completely offsetting your quality of life.
Exactly. And I just want persons to remember that you have a pelvic floor. You have muscles in your pelvis that can be contributing a lot to how you feel. Pelvic pain is linked a lot to depression. It's linked a lot to emotional health and well-being. Right. And if you can,
women, especially women,
and also in men, and obviously the incidence in women is higher, right? And if you can begin to control that, and even if your pain doesn't go away completely, but you can do more, your pain can go away to a point where you can do more and be more outgoing. And because I know a lot of times with endometriosis, the pain stops you from doing things, and you become, I always talk about the flaky friend that people say, well, Julia's not coming, so don't even bother to invite Julia. You know what I mean?
I know exactly what you mean.
So you could participate a lot more if you can take a little bit more control of your life. And reading that book,
It opened your eyes.
It opened my eyes because it's written by a gynecologist and a physio. And they kind of work together and did a lot of like manual therapy and teaching women how they can do this stuff on their own. And, you know, I really want to improve the quality of life of women, especially with endometriosis and, you know, persistent pelvic pain, particularly here in Barbados and obviously in region, because, we're trying to work in the region as well. So,
yes, that's appreciated. And, for me, I can say that I am very thankful that from that very first instance when you reached out to me when I was sharing my story, because first of all, I had no idea what a pelvic health physiotherapist was, as I said before.
Yeah.
And then when I did a little bit more research into what it was and how you work in tandem with, OBGYNs in helping women with these chronic conditions, I mean, we have this resource on island. I don't think she's being utilized to her fullest extent with her skill set.
Yeah, I will say that is something that you still has to be still to educate people.
Exactly.
There are psychologists who are really good and they will refer, but I think a lot of people still either don't know that I exist, which I'm working on,
right?
Or you'd be surprised that some people really don't know, what pelvic floor physio is, and they don't really say, oh, it can help with this, it can help with that, it can
right.
So, it's just to educate more and get the word out there.
And that's what we're going to continue to do, and we're going to push to do, and we're going to make sure that, like you said, we're going to work to help the women on island, specifically those with, I'm going to use your term, persistent pelvic pain, that has been just seen as something you just had to grin and bear. No, you don't have to grin and bear that. They're professionals who can help you, they're experts who can help you, and they can give you the tools with which you can work to improve your quality of life. And that's part and parcel as to why BAEP was created to begin with. So
I know when I reached out to you, I had no clue that it was gonna spiral down this road. When I first messaged you and said, thanks for doing what you do, and I send my patients to your page so they can see that they're not alone.
Mm-hmm.
And this is all, what really happened after.
So on that note, I'm going to let everyone know that if you want to get in contact with Jasmine and her practice, I'm going to have the information for Mindful Movement in the end card. I will also have it in the description in the content underneath. I want to, again, extend heartfelt gratitude to Jasmine, not only for, sitting in and having this discussion, but just for everything that she has done. Everything that she continues to do.
Thank you too.
Thank you
for this platform and for this idea of doing this for BA, this BAEP Talks with. And to anybody who wants to reach out to me, I'm always willing to chat and answer questions over the phone, via email.
Okay, thank you so much. I am going to now wish you a great rest of your evening, and I'll probably WhatsApp you and hear you a little later. But thank you so much again, Jasmine. Thank you to all of you who have joined us. Enjoy the rest of your evening as well, and see you next time on BAEP Talks with. Bye.
Bye.